Most people who come to me with fatigue have already explained it to themselves before they ever mention it to a doctor, and the explanation is always some version of the same thing. I am getting older. I am not sleeping well. I have too much on my plate, and I probably just need to take better care of myself. And there is enough truth in all of those things to make the explanation feel complete. So the tiredness continues, and they push through it, and 6 months later it is still there. And they explain it the same way again, and another year passes. What I want you to understand today is that persistent, daily fatigue that has been present for weeks or months and that is not explained by a specific, temporary cause like an illness or a period of unusual demand is one of the most information-rich symptoms the body produces. It is not a single problem. It is a pattern that can point toward half a dozen specific physiological failures, each of which has a name, each of which has a test, and each of which has a treatment pathway that the person has never been offered because the symptom itself was accepted as the explanation. This video is about those 6 pathways, not about general wellness advice for feeling more energized, about the specific biological mechanisms that produce persistent fatigue in adults over 60, the conditions behind them, and the clinical questions that need to be asked when fatigue has been present long enough that it can no longer be attributed to last night's sleep. Before anything else, what I share here is educational information only. It is not medical advice. Persistent fatigue has a wide range of causes, and a thorough medical evaluation is the appropriate first step for anyone who has been experiencing it consistently for more than a few weeks. What I want to give you today is the framework to make that evaluation as targeted and productive as possible. I am Dr. Andrew Carter, and I have spent 15 years working exclusively with adults over 60. Fatigue is the presenting complaint I hear more often than any other, and the pattern I see most consistently is not a person who has been given a complete evaluation and found to have nothing wrong. It is a person who has been given a routine blood panel, told their levels are normal, and sent home with the same advice about sleep and stress that everyone else receives. The evaluation was incomplete. The questions were not specific enough, and the fatigue continues. If this is your first time on this channel, subscribe right now because every week I bring you specific, grounded information about what your body is communicating after 60, and this video will change how you think about what tiredness actually means. Let me start with the distinction that matters most, because without it, the rest of this video cannot be applied properly. Normal fatigue is proportional, transient, and specific. You exerted yourself. You did not sleep enough last night. You are recovering from an illness, you have been under unusually high emotional or physical demand, and the tiredness reflects and resolves with those circumstances. Normal fatigue has a cause you can point to, improves with adequate rest, and does not produce a persistent daily baseline of exhaustion that is present regardless of how much sleep you got or how little you did. Pathological fatigue is disproportionate, persistent, and often unrefreshing. The person wakes after 8 hours of sleep and does not feel rested. They feel tired before midday, despite having done nothing particularly demanding in the morning. They need to rest during the day not because they worked hard, but simply to function. Their energy is not depleted by effort so much as it was never there to begin with. And crucially, this pattern has been present for weeks or months at a level that represents a genuine change from their previous baseline. If your fatigue fits the first description, this video will give you useful context but may not reveal anything clinically significant. If your fatigue fits the second, this video may contain the explanation you have been missing. The clinical threshold I use for recommending a targeted fatigue evaluation is fatigue that has been present most days for 6 weeks or more, that represents a change from the person's previous energy level, and that does not have an obvious and complete explanation in current circumstances. That is the line between accepting tiredness as a feature of life and pursuing it as a symptom that deserves investigation. The first pathway I want to describe is the most commonly missed in adults over 60 with persistent fatigue, and it is the one most directly connected to the modern dietary pattern. Blood sugar dysregulation and the energy instability that follows postprandial glucose crashes. We discussed this in a previous video on this channel, in the context of the post-meal symptoms that follow a blood sugar spike and drop. But the fatigue dimension of this mechanism deserves its own specific discussion, because in adults with developing insulin resistance, the daily pattern of glucose highs and compensatory crashes can produce an energy profile across the entire day that mimics the feeling of being chronically tired, even when the person's sleep is adequate and their activity levels are reasonable. Here is the physiology. After a carbohydrate-heavy meal, blood glucose rises rapidly. The pancreas releases a large compensatory bolus of insulin. Blood glucose is driven down, sometimes past the baseline, into the low normal or slightly hypoglycemic range. Adrenaline is released in counter-regulation. The brain, sensing the falling glucose, reduces its allocation of energy toward complex cognitive tasks and toward sustained physical effort. The person experiences a wave of tiredness, sometimes within 30 to 60 minutes of the meal, that can last for 1 to 2 hours. In a person eating 3 meals and 1 or 2 snacks daily, all with a high glycemic load, this cycle may occur 3 to 5 times per day. Each cycle produces a period of reduced energy. The aggregate effect across a full day is a pattern in which the person never feels genuinely energized, because every period of adequate glucose is followed by a crash, and the crashes are more noticeable than the peaks. The key clinical feature that distinguishes this mechanism from other causes of fatigue is the relationship to meals. Fatigue that worsens reliably within 30 to 90 minutes of eating a carbohydrate-heavy meal, that accompanies cravings for more carbohydrate or sweet food, that follows a brief period of reasonable energy after eating, and then drops, and that is better in the morning before the first meal than it is in the afternoon after several meals, points toward postprandial glucose dysregulation as a significant driver. The test to request is an HbA1c alongside fasting glucose, which together give a picture of average glucose control over the preceding 3 months. And the fasting insulin, which we discussed in the blood pressure video, reveals whether the compensatory hyperinsulinemia driving the crashes is present. These 3 numbers together describe the metabolic picture that sits behind the fatigue far more completely than a single fasting glucose measurement. Type in the comments right now whether your fatigue is worse in the afternoons and better in the mornings, or whether it is present equally throughout the day, because that pattern difference is diagnostically meaningful, and I want to see it. The second pathway is one that is estimated to affect more than 1 billion adults worldwide, and that, in many of them, produces persistent fatigue as its primary and sometimes only symptom for years before any other clinical consequence becomes apparent. Iron deficiency and iron deficiency anemia. Iron is the mineral at the center of the hemoglobin molecule that red blood cells use to carry oxygen from the lungs to every tissue in the body. When iron stores are depleted, hemoglobin production falls, the oxygen-carrying capacity of the blood decreases, and the body's cells, including the brain and the muscles, receive less oxygen per unit of blood delivered. The result is the particular fatigue of anemia, which is distinct from the fatigue of sleep deprivation or overwork. It is a physical heaviness, a breathlessness with minimal exertion that the person may have normalized so gradually they no longer recognize it as abnormal, a paleness that family members may notice before the person does, and a cognitive slowing that is easy to attribute to age. In adults over 60, iron deficiency deserves specific investigation because its causes in this age group are different from those in younger adults. Inadequate dietary intake is a contributor, but the more clinically urgent cause is occult gastrointestinal blood loss, the slow, invisible bleeding from a lesion in the digestive tract that depletes iron stores over months without producing any visible blood in the stool. This is the mechanism I described in the digestive symptoms video on this channel, and it is worth reiterating here because the fatigue of iron deficiency anemia in an older adult without an obvious dietary explanation warrants gastrointestinal investigation, not simply iron supplementation. A complete blood count measuring hemoglobin, hematocrit, and red cell indices tells you whether anemia is present. A serum ferritin measurement tells you whether iron stores are depleted even before anemia has fully developed, which is the stage at which the fatigue can be present, but the standard hemoglobin appears normal. Ferritin below 30 micrograms per liter in an adult over 60 with persistent fatigue warrants investigation of the cause, not just the correction of the level. Ask your doctor for a full blood count and a serum ferritin at your next appointment if you have been experiencing persistent fatigue and have not had these measured in the past 12 months. And share this video right now with one person in your life over 60 who is chronically tired and has been told there is nothing wrong in their blood tests, because a normal hemoglobin does not rule out iron depletion and does not rule out the cause of any depletion that is present. If you have not yet subscribed to this channel, tap that button now and ring the bell, because every week I come here with exactly this kind of information. I want to tell you about Dorothy, 69 years old, retired teacher from Atlanta, Georgia, She had been tired for 8 months when she came to me. Tired in a way she described as bone deep, present from the moment she woke up, not responding to earlier bedtimes or to the one rest day per week she had introduced. Her previous doctor had run a full metabolic panel and a thyroid test. Both were normal. She had been told her fatigue was likely related to deconditioning and stress and had been recommended to exercise more. When I reviewed her complete history, I asked specifically about her stools. She mentioned that they had become somewhat darker over the previous 3 or 4 months, something she had noticed but not thought significant. Her hemoglobin was 10.2 grams per deciliter, a meaningful anemia. Her ferritin was 8 micrograms per liter, severely depleted. I referred her urgently for colonoscopy. A large polyp was found in the ascending colon, not yet malignant but with high-grade dysplasia, meaning it was a precancerous change that, left in place, carried significant risk of progression. The polyp was removed. Her iron was supplemented. Her fatigue, which had been the only symptom she had ever noticed, began to resolve over the following months as her hemoglobin rebuilt. Dorothy told me, "I was just exhausted for 8 months and nobody looked for a reason." I told her, "Your fatigue was a reason. The test that revealed it just needed to be the right test." The third pathway connects persistent fatigue to one of the most common and most consequential undiagnosed conditions in adults over 60, and it is one that produces fatigue through a mechanism that is operating not during waking hours, but during the hours when the person is lying in bed, breathing, and apparently resting. Obstructive sleep apnea. The condition we have discussed in previous videos on this channel in the context of blood pressure, nocturia, and cardiac risk, and that produces fatigue through the specific mechanism of fragmenting sleep architecture and driving chronic nocturnal hypoxia. When the upper airway collapses repeatedly during sleep, the brain is repeatedly forced into partial arousal in order to restore breathing. These arousals may last only a few seconds, and the person may have no memory of any of them. But their effect on sleep architecture is significant. Deep, slow-wave sleep, the stage in which the most restorative biological processes occur, is progressively curtailed by the need to repeatedly rescue the airway. The person spends more time in light sleep than in deep sleep. They spend the night not in genuine rest, but in a cycle of partial suffocation and recovery that is physically exhausting even when subjectively invisible. The result is the specific fatigue profile of sleep apnea, and it has a recognizable pattern. The person wakes feeling unrefreshed regardless of how many hours were in bed. They frequently have a mild morning headache from the carbon dioxide accumulation of the overnight hypoxia. They may have a dry mouth. And they experience a level of daytime sleepiness that goes beyond ordinary tiredness, the kind where sitting still in a warm room for more than a few minutes reliably produces a drowsiness that is difficult to resist. A study published in the journal Sleep found that untreated moderate to severe obstructive sleep apnea was associated with significantly higher fatigue scores and significantly lower subjective quality of life ratings compared to treated adults, and that the magnitude of the fatigue improvement following effective CPAP therapy was among the largest quality of life improvements documented for any chronic disease treatment in adults over 60. If your fatigue is present from the moment of waking, if you snore or have been told you stop breathing during sleep, if you wake with morning headaches, if you fall asleep readily whenever you sit still during the day, the pathway is likely through your airway rather than through your blood or your hormones. A home sleep study is non-invasive, completed in your own bed, and delivers a diagnosis that, when treated, can produce a transformation in daily energy that many patients describe as genuinely life-changing. Just ask for it. The fourth pathway is endocrine, and it operates through 2 of the most common hormonal disruptions in adults over 60, one affecting women predominantly, and one affecting both sexes, but assessed incompletely in the majority of cases. Thyroid dysfunction, specifically hypothyroidism or the underactive thyroid state, produces fatigue through a mechanism that is as direct as physiology gets. The thyroid gland produces hormones, primarily T4 and T3, that regulate the metabolic rate of virtually every cell in the body. When thyroid hormone levels are inadequate, the cellular metabolism slows. Energy production from mitochondria decreases. Every tissue in the body becomes less metabolically active. The result is a profound and characteristically persistent fatigue that is present around the clock, that is not improved by sleep, and that is typically accompanied by other hypothyroid features, including weight gain without dietary change, cold intolerance, constipation, dry skin, and cognitive slowing. The critical point I want to make about thyroid evaluation in the context of fatigue is the same point I made in the blood pressure video. Testing only TSH, the thyroid stimulating hormone, gives an incomplete picture of actual thyroid hormone function. TSH reflects what the pituitary gland is signaling to the thyroid. Free T3 and free T4 reflect what the thyroid is actually producing and what is circulating in the tissue. A TSH within the reference range does not confirm adequate thyroid hormone at the tissue level, particularly in adults whose thyroid gland has reduced reserve capacity. If you have had your thyroid tested and the result was normal, ask specifically whether free T3 and free T4 were included in that assessment. In women over 60, declining estrogen in the postmenopausal state produces fatigue through a different mechanism: disrupted sleep architecture, reduced energy metabolism, and impaired recovery from physical exertion. Estrogen deficiency after menopause affects mitochondrial function in muscle cells, contributes to insulin resistance, and disrupts the sleep quality that is the foundation of daily energy. Many women experience this as a gradual worsening of energy levels across the menopausal transition that they attribute to aging rather than to the specific hormonal change driving it. A conversation with a physician about hormone levels and whether hormonal support is appropriate, given the individual risk profile, is worth having. If you are not yet subscribed to this channel, tap that subscribe button right now and ring the bell, because every week I bring you the level of clinical detail that makes these conversations with your doctor more specific and more productive. The fifth pathway is cardiovascular, and it is the one that, when it is present, carries the most significant long-term implications beyond the fatigue itself. Heart failure, even in its early stages, and more broadly any reduction in cardiac output that limits the delivery of oxygenated blood to the muscles and the brain, produces fatigue through a mechanism that is fundamentally different from the other causes I have described. It is not a failure of energy production within the cell. It is a failure of delivery. The oxygen and nutrients the cell needs to produce energy arrive in insufficient quantity because the pump driving the circulation is not maintaining adequate output. The fatigue of cardiac origin is characteristically worse with exertion and better at rest, which is the opposite pattern from most other causes. The person who is tired in general but specifically notices that climbing stairs or walking a certain distance produces a disproportionate fatigue compared to what it required a year ago, and who then needs an extended rest to recover from that exertion, is describing a pattern that should trigger cardiac evaluation. Breathlessness on exertion alongside fatigue is the additional feature that most significantly elevates the urgency of this evaluation. When the heart is not maintaining adequate cardiac output, the body compensates by increasing the breathing rate to maximize oxygen extraction from each breath. The person who notices they are breathing harder than expected when climbing stairs, carrying groceries, or walking briskly, and who attributes it to being out of shape, may actually be experiencing the early compensation of a struggling cardiac system. A study published in the journal Heart found that unexplained exertional fatigue in adults over 60 was associated with a significantly higher rate of previously undiagnosed cardiac pathology when it was specifically investigated with echocardiography and functional testing compared to routine blood work alone. The standard blood panel, including the full metabolic panel that many adults receive annually, does not assess cardiac function. Fatigue with an exertional component requires a specific cardiac evaluation, including an ECG and, depending on the clinical picture, an echocardiogram. If your fatigue is consistently worse with any physical effort, if you are breathless with activities that previously required no particular exertion, or if you have any history of hypertension, diabetes, or elevated cholesterol, please bring the exertional dimension of your fatigue to your doctor specifically. The word exertional changes the clinical pathway. The sixth pathway is nutritional and inflammatory, and it covers a collection of deficiencies and chronic conditions that, while individually less dramatic than cardiac disease or sleep apnea, are extremely prevalent in adults over 60 and are among the most correctable causes of persistent fatigue once they are identified. Vitamin B12 deficiency, which we have discussed extensively in previous videos on this channel, produces fatigue through its role in energy production at the cellular level and through its effects on myelin maintenance in the nervous system. The fatigue of B12 deficiency is often accompanied by cognitive slowing, by peripheral tingling or numbness that the person may have normalized, and by a general sense of neurological sluggishness that is distinct from the physical heaviness of iron deficiency anemia. As we have established, the standard serum B12 measurement can appear normal, while cellular B12 sufficiency is actually poor. Methylmalonic acid and homocysteine are the tests that reveal cellular B12 status, and they should be specifically requested rather than assumed to be covered by a normal serum B12 reading. Vitamin D deficiency, also prevalent in adults over 60 and also frequently undetected, produces fatigue through its role in mitochondrial energy production and through its effects on muscle function and immune regulation. The muscle weakness and heaviness associated with vitamin D deficiency can be experienced as fatigue because the effort required for normal daily activities is increased when the muscle tissue is not performing at its optimal capacity. Beyond individual nutrients, chronic low-grade inflammation, the systemic inflammatory state driven by insulin resistance, by gut dysbiosis, by ultra-processed dietary patterns, and by the cumulative oxidative burden of aging, produces fatigue through the cytokine mechanisms we discussed in the muscle mass video. Elevated levels of pro-inflammatory cytokines, including interleukin-6 and TNF-alpha, directly suppress the neural and mitochondrial pathways that produce subjective alertness and physical energy. A person with chronic inflammation at a subclinical level will feel persistently tired because the same inflammatory signaling that produces the fatigue of an acute illness is operating at a lower but continuous level. An elevated CRP, the C-reactive protein that is a standard marker of inflammation, in the context of persistent fatigue without another clear explanation, suggests that reducing the inflammatory burden through dietary pattern, blood sugar management, and adequate sleep may produce meaningful improvement in energy. Here is the complete evaluation framework I want you to bring to your next appointment if you have been experiencing persistent fatigue. Ask for a complete blood count to assess for anemia. Ask for serum ferritin specifically, not just hemoglobin, because depleted iron stores without frank anemia are common and produce fatigue. Ask for HbA1c and fasting insulin to assess the metabolic picture. Ask for a full thyroid panel including free T3 and free T4, not just TSH. Ask for vitamin D, vitamin B12, methylmalonic acid, and homocysteine. Ask for CRP as an inflammation marker, and describe specifically whether your fatigue is worse with exertion, because that single feature indicates whether a cardiac evaluation needs to be part of the workup. If you snore, wake unrefreshed consistently, or have morning headaches alongside persistent fatigue, ask specifically about a home sleep study for sleep apnea. If your fatigue worsens predictably after meals and is accompanied by afternoon energy crashes, ask about the postprandial glucose picture and about fasting insulin. If you are a woman over 60 and your fatigue has been progressive over the past several years, ask specifically about estrogen levels and the evidence for hormonal support given your individual risk profile. None of these investigations is exotic. They are standard tests that can be ordered in a single blood draw. What they require is that you ask for them specifically and describe your symptom with enough precision that the clinical picture points toward the right tests. Type yes in the comments right now if you have been experiencing persistent fatigue for more than 6 weeks and have not yet had a targeted evaluation that includes ferritin, B12, fasting insulin, and free T3. Because the gap between normal blood work and a complete fatigue evaluation is exactly those 4 tests, and they represent the difference between reassurance and an answer. 4 things to carry away. First, persistent fatigue that has been present most days for 6 weeks or more and represents a change from previous baseline is a clinical symptom that warrants targeted investigation, not acceptance. The 6 pathways I described, blood sugar dysregulation, iron deficiency, sleep apnea, thyroid dysfunction, cardiac limitation, and nutrient deficiency with chronic inflammation, are all identifiable with appropriate testing and all treatable once identified. Second, the standard blood panel that most adults over 60 receive annually does not cover the complete fatigue evaluation. Ferritin, fasting insulin, free T3, free T4, methylmalonic acid, homocysteine, and vitamin D are not standard panel components and need to be specifically requested. Normal standard panel results do not mean a complete evaluation has been performed. Third, the exertional quality of fatigue is the single most important descriptor to provide to a doctor evaluating this symptom. Fatigue that is consistently worse with physical effort and improves with rest points toward a cardiac delivery problem that requires a different investigative pathway from fatigue that is constant regardless of activity. Fourth, Persistent fatigue in an older adult with iron deficiency that does not have a clear dietary explanation warrants gastrointestinal investigation, not just iron supplementation. The depletion is a signal that blood is being lost somewhere in the digestive tract, and that source needs to be identified. Your energy is not a luxury or an indulgence. It is a functional measure of how well the systems sustaining your body are operating. When it diminishes persistently and without a clear temporary cause, your body is telling you that one or more of those systems is under a load it cannot fully meet. That information has a source. The source has a name. The name has a treatment. And the path to finding all three begins with the right questions at the right appointment. You are not simply tired because you are getting older. You may be tired because something specific is happening that nobody has yet been given enough information to find. That changes today. Share this video with someone you care about who has been exhausted for months and has been told everything looks fine in their blood work. Because fine on a standard panel and fine on a complete evaluation are not the same thing. And subscribe to this channel because every week I come here with one purpose: to give you the specific information that turns a vague complaint into a targeted answer. Aging does not take away your body's ability to recover. It simply reminds you to care for it the right way. Take care of yourself.